So I'm just connecting the YouTube channel. Take a minute. Sorry. Good evening, everybody, and welcome to the 28th iBreastBook webinar, which here we're iBreastBook meeting Oncoplastic Academy. So it's great to have all the colleagues from South America today. And what we decided to see, to look at controversies, so things that might be done differently in different parts of the world. It's great to see that nearly 300 people are online already. I know it's Ramadan for many people in the Middle East and the subcontinent, so happy Ramadan for everybody, and I hope that will not affect the attendance that much. We have a great faculty and we have great speakers and panelists. We'll introduce everybody when we go to the discussion part when we come to the panelists, but now we'll just start with the talks. So we'll finish all 3 talks and then we'll go for the questions. Now, if you have any questions, please go on the question and answer section. Please don't use the chat section because we already have 23 messages in the chat section. So if you will have any questions, please put it on the question and answer section and we'll try to answer most of the questions. And if you want to listen to the talks in Spanish, we have the lovely Ricardo Pardo who's going to do immediate translation for us. So you just need to go on the globe on the lower part of your screen next to the Q&A section and choose Spanish and you can hear Ricardo. So we'll start with the talks and the first speaker will be introduced by Giuseppe. Giuseppe?
Hello everyone, thank you very much Yazan. Thank you also to the Oncoplastic Academy. I'm one of the moderators of this webinar tonight, and the first speaker will be Professor Cicero Urban. Maybe everybody knows Cicero. He's a surgical oncologist, a breast surgeon. He works in Curitiba. He's the head of the Oncoplastic and Reconstructive Surgery division at the Centro de Docenza de Mama in Curitiba in Brazil. Everybody knows that Cicero has an international training, and he was a fellow of Umberto Veronesi and Mario Rigens in Milan, in my country. Is totally dedicated to oncoplastic and reconstructive surgery of the breast. He manages a course in Curitiba that in the past, to whom in the past we contributed on cadaveric dissection and oncoplastic surgery. Thank you very much for being with us, Cicero, and the microphone is yours.
Hello, everybody. Thank you, Giuseppe, for the introduction. Your friends. So, to me, it's a privilege to be here with this great team of speakers and partners from Brazil and from other countries. I will share my screen just a minute. Well, the idea here is to do this topic in a philosophical way. The ideal training pathway for breast surgeons. I will put some of our ideas about this important topic. I don't have conflict of interest here to disclosure. After 20 years, I'm sorry, my microphone is not, just a minute.
It's working now fine, Cicero.
Yeah, but it is open, just a minute.
Yeah.
Okay. Sorry for this. What I will present here represents my personal opinion after 20 years of practice and being responsible for the education and training of surgeons from different countries. So it is not perfect. In summary, my presentation will be divided in 3 topics. The first one, what are the obstacles to the oncoplastic global development? And the second part, we'll try to systematize and the future of breast surgery, certification or specialty or both. I'm having again problems with my, just a minute. Sorry for that. Because I have AirPods having problems. Okay. And the third one is the future of breast surgery, certification or the first topic in this part. It is now based on more evidence, but with lack of strong data in some important issues. That's the problem that we have today. A good number of oncoplastic leaders in the field that can help the new oncoplastic surgeons or the new breast surgeons to work with, and a great interest by the part of surgeons. Of course, we are much better than some years ago. As you can see here, we have lots of papers published in the recent years. For example, 2020, 2021, a large number of papers. And specifically talking about training, now more than 100 papers that can help us with this important topic and difficult to deal with in our practice. But, and we have a big but here, unfortunately, training programs are still rare in most countries, and it is not part of residence training, most of them. There is little standardization with the challenges, it's scientific evaluation. We can compare one program with other with great difficulty. And there's little consensus on training curve. Learning oncoplastic is a lifelong journey, not a single event. So this is difficult to us. And according to me, in my opinion, the main obstacles to oncoplastic development is the first one, demarcation issues between surgical subspecialties, turf war between specialties, insufficient availability of training centers in the world. There is no global model for training surgeons, and oncoplastic training is not evidence-based until now. So we should build a model for training which should be global and international. In this study published in 2016, Canadian surgeons thought that the most important barrier identified by them was that they were unfamiliar with oncoplastic techniques. So they didn't have trained in oncoplastic techniques. And that's why they don't perform it in their practice for many cases. In the beginning, until 2016, I thought that it was due to turf war between specialties. But there is something more included in the pocket, not just turf war between specialties. We have something that we had in the past, and in Brazil, we don't have it anymore, but it was in the beginning very strong, a subliminal obstacle, which was the generation differences in oncoplastic training and practice. And by generation differences, I mean what you know, traditionalists, millennials, Z generation, X generation, and so on. And nowadays we have 4 to 5 generations in the theater, something very, very good in one point of view, but we had some difficulties in the past because as you can see, the icons and heroes in different generations, they are different. And also the ethic in relation to authority, they are completely different between generations. What we had, this conflict of generations, generated 8 years from Halsted until Veronese. It was something crazy that we've been done by 8 years the same surgery until arriving at the point that it was necessary to change, and the Veronese legacy was completely different. So to achieve this point, it was necessary to break some paradigms, and Oncoplastic is a new paradigm. Systematization of training in oncoplastics, is it possible? The answer is yes, it is possible, but it is very difficult because we have different, not only different generations, because the old generation of breast surgeons in Brazil, they said to us in the beginning that it was not possible for a breast cancer surgeon think about aesthetics, because you do a bad surgery for the patient, a bad oncological result, and it was not true. We proved that it was not true. But the systematization of training, we have some difficulties, not because of the theory, because of the practice, because we have different cultures, we have turf wars in different countries, we have, for example, not well-established training for breast surgeons. In Brazil is different, for example, from UK and from the United States. This was the first meeting that we had in New York in 2010, trying to systematize this way of thinking. In this training, we have a classification with Gail Lebovec in 4 different competences. Level 1 was monolateral breast surgeries that we do in our practice, even without plastic surgeon training. Level 2 was bilateral surgeries, and level 3 implants, and level 4 flaps. Oncoplastic surgery is an aesthetic cancer cure. It's completely different that we had in the past. And breast is an aesthetic and functional organ. It's important that rigid boundaries between surgical oncology and reconstruction surgery compromise the final results for the patient. Today we know it. Oncoplastic follow all oncological principles, so it's not necessary to do a clinical trial to prove that it works. It's a technical refinement. We are not changing the oncological principle. We are giving more for the patients about their results. It's necessary to combine the skills of the cancer surgeon with those of the plastic surgeon. So we came from breast conservation until now, which is the aesthetic cancer cure. In the beginning, the aim was to avoid mastectomy. Nowadays, we are discussing about symmetry, about appearance. It is necessary to have a strong ethical concepts, because the patients should be advised about some expectations and some risks which are different from the past, and to respect patients' autonomy in terms of techniques that we will put the patients inside. And the combination of both breast cancer surgery is always an oncoplastic surgery, always, because we should always think about aesthetics. And the models of training, we have lots: cadaver labs, animal models, simulators, residence training, fellowship, and we have an open horizon to this kind of training. We should have some skills and competences which are completely different from the past. Pre-op decisions, indications, contraindications, limits, plannings, photos, patients' expectations, autonomy, inter-op technical skills in different techniques, and post-op in complications. And we should learn how to see the breast: site, size, skin, shape, symmetry, these 5S variables in oncoplastic surgery. They should be very clear to us since the beginning. Well, if we master just three techniques in plastic surgery, we can solve more than 90% of our breast conserving treatment cases. So superopedical, inferiopedical, round blocks. So in terms of technique, it's not so difficult. The most difficult part is changing your way of thinking, is to see the patient and to plan the surgery. And that's the way we should try to put our fellows and our residents in a different way of thinking, in order to try to give them the opportunity to arrive in the proficiency, practice without supervision. They begin in the this part and they should arrive until here. Of course, it could be perfect if we can have some of them as supervisor of the others. And how to develop a global training strategy. First, you should do the diagnosis in your country. It is essential to know how the oncoplasty is being carried out in your reality, what are the barriers to oncoplastic practice, and then begin programs of surgical education for old surgeons who have not the opportunity to do this in their training, formal residence training, which is the key point to change the reality. It's to put it inside the residence training and then integration into practice. At the end, we should have a self-sustaining critical mass of fully trained surgeons and training other colleagues to be trainers too. And it's important to have a collaboration between different countries because we have different realities. The third part of this presentation is the future of breast surgery, certification, specialty, or both. And I disagree with this guy. I think that we have a shiny future for breast surgeons using oncoplastics inside our background. And how to train the future generation of breast-focused surgeons, formal education, and a global curriculum. Breast surgery should be a specialty. We need to change it in many countries. In Brazil, we are already breast specialty since many years ago, since the 1990s. UK, we have two models of formal training. The UK model, where oncoplastic is a subspecialty incorporating both general and plastic surgery in a curriculum by a very competitive application. And in Brazil, we have the Brazilian model. Mastology is a certified surgical specialty, and oncoplastic is regularly incorporated in the program since the beginning of residence training. What's the difference between one another? The oncoplastic experience in Brazil, in terms of training, most of our residents have the training in oncoplastic in all period of 2 years of residence. It is good. Some of them until now don't have training in oncoplastics, and some of them remains with a stage in plastic surgery 3 months. But most of our breast units in Brazil are training their own residents and fellows since the first day of their residence training. The advantages and vulnerabilities from both systems. UK model as a subspecialty, we have clear advantages that are specialized at oncoplastic surgeon, like a tertiary surgeon doing working and helping the others with the surgeries. The vulnerability of this model to a country like Brazil, which is very big, we have more limited in number of available surgeons. The advantage of the Brazilian model is that we have more breast surgeons offering oncoplastic techniques to the patients. And this is very clear to us, which we are living in Brazil. You have a big specialty, and many patients, even in the public healthcare, are receiving these techniques because of the training. But the disadvantage is that we don't have not all residents able to do the full range of oncoplastic techniques in the 4 levels until the flaps, for example. So which model is better? Both are complementary. Both are necessary to try to do something different in your realities. So we don't have one better than other. And this is our idea of the complete training in skills and now techniques, a global curriculum to the breast surgeon, breast focused surgeon. We should have some knowledge in clinical oncology, breast clinical oncology, radiotherapy, radiology, pathology, oncogenetics, ethics, and leadership, because breast surgeons, oncoplastic surgeons are leaders in their teams. It should be, of course, patient came to us first, then go to the clinical oncologist, for example. Cancer surgery, reconstruction, and aesthetics. That's the way to change and to create a richer specialty in our realities. In conclusion, multidisciplinary oncoplastic approach can offer more to the patients. A productive exchange of knowledge and training between medical specialties is important, is fundamental to us in this moment. Breast cancer surgery is oncoplastics and should be optimizing both oncologic and aesthetic outcomes. Implants, autologous, tissue-based, and cosmetic techniques should be included in the skills in order to have a better aesthetical and oncological results. It is essential that breast surgeons be trained in the full range of oncoplastic techniques. Availability of oncoplastic training is currently insufficient. Incorporating oncoplastic is now a moral imperative. And formal oncoplastic training programs are the way to ensure that patients are offered all available options for which they are suitable. Thank you very much for your attention and for being with us today. Sorry for the problem with my AirPods.
That's great, Cicero, and many thanks for a great presentation. I think there's lots to discuss, especially with Linda and Anne at the end of this. Now, lots of interesting things that I've seen here, Cicero. Let's go for the second talk first. And we have Maurizio Rezende, who's going to talk about breast conservation and the augmented breast. And Maurizio is also one of the surgeons from Brazil, and he does lots of subspecializes in oncoplastic and reconstructive surgery and has authored many things, mainly with Cicero and Regis. And it's a pleasure to have Maurizio with us today. Maurizio, the next 15-20 minutes are all yours.
Thank you, Hassan. Thank you, Giuseppe, to be here with you. It's a very, very, very big pleasure to be here with you. And I try to talk something about...
Maurizio, we don't see you.
Don't you see me? I'm trying to share my screen.
No, we can see the screen, Maurizio. The screen is fine, but if you start your camera, then we can see you also along with the screen. That will be great.
Let me try.
Don't worry.
Yeah.
Yeah. Okay. Yeah, share the screen.
Yes.
Sorry, Hassan. Sorry, Regis.
That's not an issue. I think we will not see you, but we can hear you and we can see the screen. So if we go on with the presentation, that's great.
It's okay? The screen? Okay, let's try to talk something about breast conservation in augmented breasts. Let's bring some literature about this. We have dates from American Society of Plastic Surgeons, and how big is breast augmentation? We have the last dates that they have is about 2018, and we have 313,000 procedures of breast augmentation, increasing 4% from 2017. We have breast augmentation in age 30 to 39 years. We had in the United States only 116,000 procedures, increasing 5% in this age, and present this procedure in 37% of static procedures of ladies. Then it's a very, very important procedure. Breast augmentation continues to be the top cosmetic surgical procedure and has been since 2006. It's a reality, especially in Brazil. We live in a tropical country, and we have sun, we have beaches, we have swimming pool. And for ladies, we have the culture about breasts. The ladies use short bikinis, short. They live. The breast is normally seen. A lot of it's very frequently ladies using short clothes. Then the breast is very important for the appearance of the ladies. We have some literature too about neuroticism level and life satisfaction in women undergoing breast augmentation. As a preliminary report. They concluded that life satisfaction level was increased 1 year after breast augmentation. Neuroticism level didn't change. Then the image, the satisfaction is more than just sex, just eroticism. Breast cancer after augmentation oncoplastic, treatment by skin sparing, mastectomy, and immediate reconstruction. This is a very interesting literature too, where you have breast conservation has been associated with poor cosmetic outcome. And majority of the patients who develop cancer after augmentation are treated by total mastectomy. We had in this paper some results where we found unsatisfactory result in 57%, 65%, 67%. Then what we think when we read this paper is, if we have a breast augmentation, the best is the mastectomy, because the result probably won't be good. That's our conclusion after the lecture of this paper. Breast cancer following augmentation oncoplasty case control study. This was made by Scott Spear, and we had augmented breast patients had higher mastectomy rate compared with non-augmented, 72% and 57%. Augmented patient had detection of smaller size tumors than non-augmented. Some authors suggest potential tumor involvement of the implant capsule. Mastectomy can prevent capsule contracture after radiotherapy in conservative surgeries. Then we have two in this paper. I must think about mastectomy after augmentation mammoplasty, because we can have a lot of problems. We have some dilemmas that we need to try understand. We're working now with small original breasts. Conservation is normally followed by radiotherapy. Keep symmetrical breasts at the end. It's important. We must think in both breasts. What to do with the capsule? If we can have sometimes capsular compromised. And probably the most important, and this is the most important point that I have. We have vanity ladies that are looking for us, treat her or treat them, and their vanity, special vanities. Let's know our lady from today. We have DMT, 42 years old, asymptomatic, BRADS 5 at routine mammogram, BRADS 5 at ultrasound. Physical exam, normal. Me, I asked her, what do you think about your breasts? She answered me, I love my breasts, but, and the but is very important, when I was younger, before babies and breastfeeding, they were better. Then we have a problem. She has breast cancer, and she has breasts today that previously were better. She fed me. Comorbids, no desire. What's your desire? Breasts like younger. Now they're smaller. Then let's try how can we help her or no. Augmentation. She performed her surgery 7 years before, and she's now using 260 centimeters cubed from high profile. Genetic mutation, no. And she's our passion. Beautiful breasts, adequate for her profile, physical profile, but she has a cancer, and we have a problem. The easier you have a cancer, you have augmented breast, then the better is take out your breast and use an implant as reconstruction. That's it. Perhaps this is easier, but the question is this the best? This preoperative design, where we have a drawing showing a tumor and upper outer quadrant with 1.8 centimeter. Deep is not palpable, okay? We cannot palpable. We can see at the mammogram, there's the tumor. It's close to the capsule, but not in the capsule and far from the skin. Then we can keep the skin as it is, no problem. Our targets for the patient: treat cancer, of course, breast and axilla, and how Cicero talked, we need treats. We have a breast cancer, and after we think about things. Do not bring aesthetic loss, increase volume, she desires, symmetrization, of course, and of course, let it be a safe procedure, aesthetic and oncologic procedure, of course. Let's start our surgery. Incision to the chest wall. Then we'll start. This is the very important point. The tumor, and we must incision to the chest wall, not to the implant. Then it is perpendicular to, is 90 degrees to the floor, to the chest wall. It's very important because we must have, after the surgery, some protection tissue to cover the implant, the new implant. Opening the capsule and explantation, of course. No problem with the implant. No seroma, nothing. And the tumor is far from here. We're looking for a tumor that upper outer quadrant, close to axilla. And take out. Okay. Capsulectomy. I think this is a very important point. We must take out all the capsule. We'll put another implant. We probably will use radiotherapy. Then if we have some smaller grade of contracture, but it's better if we take it out. Now we have the finish with whole capsule with us. It's okay. The whole capsule. Okay. Now we perform the lumpectomy. We are in inframammary fold. We are working on the upper outer. Then especially we must have always fingers and direct lights, of course. The final aspect. The whole. At this point, I'd like to spend 1 minute saying I performed a big incision. That was the incision was made, but I can work with a smaller incision. And Cicero Urban in Brazil has some experience using a small hole while he works with indirect vision, with like laparoscopy, and using a small incision to take out the tumor. But I can think this way. This is the final aspect where we have the capsule, the tumor, and I fix or not. But I think it's better to fix to help to the pathological exam. The final review. it's a clean surgery, no bleeding, not difficult. It's too easy. We performed another skin incision to the sentinel node, okay? And clean up with saline, that's it. Let's implant. We use iodine solution to the new implant. And here we have a very important point. We must close the incision with at least 3 plans, where the first one is used an non-absorber like nylon to fix and to suture more 2 or 3 plans more to close the total wound. Now in this case I use a nylon. I remain with the implant very far from the skin, and this is very important. The final aspect. We have this patient before with 260, and it changed because she was desiring this, and we treated her, and we performed with a bigger implant with 308. That was the side that she was thinking better. The final conclusion: yes, it's possible and safe breast conservation in the augmented breast. Thank you very much.
So, thank you very much once again, Mauricio. Very interesting topic. And I think that the next topic that will be led by Regis Paulinelli as a topic, share a topic with the previous one, which is radiotherapy. And one of the reasons why breast conservation was not performed was just because after breast conservation, you have to irradiate an implant in augmented breast. Let's go now to talk about implants and radiation in the post-mastectomy setting. I mean, breast reconstruction, not only implants, of course. And we'll have Regis Paulinelli. You know very well Regis. He works in Brazil as well. He's, again, a dedicated oncoplastic surgeon. He's particularly devoted to communication, to organize courses, and is also a very important author of papers and textbooks. And again, like Cicero, he has an Italian background. He trained in Milan as well with Mario Rigens and Professor Veronese as well. So let's talk about the controversies in breast reconstruction and radiotherapy. Thank you, Reggie.
It's a pleasure being with you. I'll just share my screen. Okay. Sorry. Okay. Now I'm ready. Thank you for the invitation. It's a pleasure being here. My name is Regis Paulinelli. I work at the Federal University of Goiás and at a cancer hospital here in Brazil. Many thanks to my friend Yassan Massanet for the iBreastBook invitation, for the opportunity to the Oncoplastic Academy to be here in this webinar. Congratulations, Yassan, for your fantastic work in benefit of breast oncoplastic surgery. I'll talk in the next 20 minutes about how to handle breast reconstructions in case of radiotherapy. It's a tough talk because everybody knows how much the radiotherapy can affect the breast reconstruction. Although there has been a great improvement in radiotherapy techniques and equipment in recent years, breast reconstruction will always be affected by radiotherapy, and the indications for radiotherapy only increases over time. For example, in the case of single positive node after mastectomy, but the problem is not radiotherapy, it's part of the solution for cancer cure. We, in breast reconstructions, are the ones that have to adapt to achieve satisfactory aesthetic results. I'll try to give you some advice based on scientific evidence, if possible. We don't have too much scientific evidence for all our questions, but for example, this large multicentric prospective cohort in the United States on local therapies and quality of life in young women with breast cancer shows much better breast satisfaction for conservative surgery compared to unilateral or bilateral mastectomy, especially when radiation therapy is required. We are creating a database of our patients who have completed all stages of breast reconstruction and returned after at least 6 months of surgery and radiotherapy. In the spatial analysis of 567 patients, partial breast reconstruction or oncoplastic surgery led to much better satisfaction using the breast Q, much fewer complications, at the same rate of local recurrence as mastectomy, and with a smaller number of surgeries. Everybody can show beautiful results at conferences, but don't want to show complication and bad results. The first lesson to be learned is that it's much better to do a partial reconstruction than a total breast reconstruction whenever possible. Precisely for this reason, when there is a clear indication of radiotherapy, and we know that it will be more difficult to achieve a good result after reconstruction, it's worth considering conservative treatment. We have recently published a systematic review on the literature on conservative surgical treatment in case of locally advanced breast cancer. I invite you to read it. There's a lot of scientific evidence for its safety. Unfortunately, there are no randomized trials, but there are lots of level 3 and level 2 evidence that conservative treatment is safe and effective in these cases. I also don't think, just to agree with Professor Mauricio, I don't think that it's better to do a mastectomy just because the patient has a previous augmentation. We know that there will be more risk of capsular contracture. In this paper from Krishna Clough in France, for example, a capsular contracture rate was 34%. But we can handle these complications, change in implants, associating mastopexy and fat grafting, as in this case, whenever necessary. Another tip: if you realize that the classic conservative treatment can generate some considerable aesthetic sequelae, it's better to plan some oncoplastic technique from the beginning, because the irradiated tissue is very sensitive to necrosis, retractions, and other complications. The possibility of problems and bad results is much greater, and we try to correct some sequelae after radiotherapy. I once had a patient in my private office, for example, that made a quadrantectomy, in whom I made a quadrantectomy. After many years, an excellent plastic surgeon in my town, who was his nephew, convinced his aunt to have a conventional mammoplasty. The patient had almost a complete breast necrosis. The skin remained, but the fatty tissue had fistulated, and the patient barely had a breast at the end. In irradiated tissues, I prefer to make only small adjustments to the skin and to the position of the nipple complex. Sometimes I do some fat grafting to complete volume or to correct errors of retraction. On the contralateral side, yes, conventional mammoplasty for symmetrization, like in this case. This is the result after a single procedure. And we must be very careful to operate on irradiated breasts. When it's really necessary to perform a mastectomy, we have to choose between two options: an autologous reconstruction or an expander, and an implant-based reconstruction. This large meta-analysis showed that the risk of reconstruction failure was 7 times higher with implants. The risk of infection 3 times higher. On the other hand, necrosis was 3 times more common after a flap. There is no difference for hematoma, dehiscence, thrombosis, and reoperations. But in the case of radiotherapy, there was a large advantage in this paper in favor of flaps regarding complications and reoperations. And so in this case, a flap is very welcome. When choosing the reconstruction technique, we must always consider 3 objectives: aesthetics, safety, and easiness. I repeat that in any circumstance, a conservative treatment and partial reconstruction will be the best option whenever possible. Flaps have a better aesthetic result and fewer complications, especially in the long term in comparison to implants. On the other hand, implants are the most common option nowadays for breast reconstruction, mainly because of their easiness and speed. This large American multi-center study, including 2,000 women, showed that reconstruction failure in 3 years ranged from 1% in the case of flaps to almost 20% in the case of implants, when radiation therapy was needed. And a very important detail, the latissimus dorsi in association with implants, which is a good solution to reduce complication in the case of radiotherapy, has not been considered as an autologous reconstruction. Surely the failures of reconstruction will be even greater if we consider only expander and implants without the LD. Another advice, attention to bilateral reconstructions, with especially in large or two medial implants, because it can make life difficult for the radiation oncologist. Planning radiotherapy is going to be more difficult in these cases. He will sometimes have to choose between irradiating the contralateral breast or irradiating the lungs and heart. In my opinion, also bilateral mastectomy is usually a poor choice for most patients, especially in some except in some very high risk patients, such in the case of high penetrance mutations. There is no evidence that bilateral mastectomy procedures have better outcomes than conservative treatment. This meta-analysis with 62 studies with more than 15,000 women with prophylactic mastectomy showed that 10% of the women regretted their decision, 15% were dissatisfied with the aesthetic results. There were additional unplanned surgeries in 60% of breast reconstructions. Half of the women found that the aesthetic results worsened after surgery. 1/3 had psychological problems and 2/3 had pain and discomfort. In my opinion, contralateral mastectomy does not guarantee better symmetry. Usually it's just more risk of problems, especially if radiotherapy is planned. In the case of a total breast reconstruction, we have two situations. The patient who comes for a reconstruction after radiotherapy and that needs to radiate the reconstruction. The other hand, the women that need to radiate the reconstruction. Reconstructing irradiated tissues with implants is risky. We know from literature that there will be a 70% risk of complications in immediate reconstruction and 50% in late reconstructions. We'll have 40% of implant loss and conversion to flaps. My first option in this case is to make a latissimus dorsi of a tram flap, as in this case. In the case of latissimus dorsi, for latissimus dorsi should also be very well selected, since it is a flap that does not provide enough skin to replace all the irradiated tissues. When the local conditions are really bad, I prefer a tram flap or a DIEP. DIEPs and other microsurgical techniques aren't very popular in Brazil because of its complexity and its higher risk of necrosis. when we operate on a patient of higher risk of necrosis, like overweight or previously a smoker, I perform an automation of the trunk flap some weeks before at the time of the at the time of the mastectomy. The results are good. We had only less than 5% of small partial flap necrosis, and large necrosis are extremely rare. The other situation is radiotherapy after implant reconstruction, and it's somehow less problematic, but we will still have around 50% of grade 3 and grade 4 capsular contractions and 30% of failures with time. Classically, what we try to do, as in this case, is capsulectomy, capsulotomy, and change of implants. It's expected still another 50% of capsular contracture after the exchange. Some cases evolve very badly. We don't know exactly why. As in this case, the patient was reconstruction with an expander with a good result without contracture. We irradiated it, we changed it for an implant and made a contralateral breast augmentation. After 1 year, there was such an intense contracture that the skin became necrotic and we lost the implant. In some cases, we don't even try an implant-based reconstruction. When we see that the expander is too high, out of position, we prefer to make a flap, as in this last case. This work by Peter Cordeiro from the Memorial in the United States is very interesting. It's the experience of a lifetime in front of one of the largest cancer hospitals in the world. He found that radiotherapy greatly increases complications, as other studies also showed, but interestingly, when the expander is irradiated, we have more failures. On the other hand, when the implants were irradiated, we have more capsular contracture. Dr. Mauricio Nava, also from Greta, had a similar study and similar conclusions. I saw with great interest this small randomized study by Dr. Ribuffo from Italy for irradiated patients, in which they did 1 or 2 sessions of lipofilling before changing the expander for the implant. And there were much fewer complications and less capsular contracture. We have a high volume of patients to operate every week, and in public hospital in Brazil, it's difficult to bring the same patient to the operating room many times. So I try to do the fat grafting in the same procedure just before removing the expander, and the results were amazing. We have already operated on more than 20 patients in this circumstance, and instead of the expected 50% of capsular contracture, we do not have any case of contracture so far. Some of the patients have more than 5 years after surgery, like this one without capsular contracture. 2 patients have infections and lost their implants. It's a failure rate of 10%, which can be considered acceptable in the case of radiotherapy. Dr. Peter Cordeiro, for example, had a 32% failure in 6 years in this situation. Another option to prevent capsular contraction is the use of ADMs. Some small studies showed its usefulness in reducing capsular contracture. The problem is the price. In Brazil, the public health system does not pay for it, nor do many private health insurance. ADM's cost may be more expensive than all other costs combined: hospitals, surgeons, anesthesiologists, medications, implants. So I only used it in less than 10 cases, all of them irradiated breast with good results so far. Some other studies show, however, an increased risk of infection and loss of implants with ADMs. The only randomized study, this one, showed that much higher risk of complications in the ADM group. But I see a problem with this study. The 2 groups are highly heterogeneous because they compare 2-stage reconstructions with expander and implants in one group and direct-to implants plus ADM in the other group. The literature has already shown an increased risk of complications in direct-to implant reconstructions, even without ADMs. And so we don't know if the extra problems if because of the ADMs. Maybe yes, but we don't really know. There are many doctors performing prepectoral reconstruction, and most of them associate ADMs. In selected case, I do the prepectoral reconstruction without ADM. This meta-analysis of some retrospective and prospective series didn't show much difference in terms of complications in the case of prepectoral and retropectoral reconstructions. Interestingly, there was less capsular contraction in the prepec. We don't know if the muscle retraction, especially in the case of radiation therapy, is responsible for the contracture, or if ADM really helped reduce capsular contracture. Here we see a case of severe contracture and asymmetry. We used the latissimus dorsi to solve the problem. More recently, in similar situations, we have achieved good results with immediate fat grafting, capsulotomy, and implant exchange as the second example. They are very similar, but we managed to solve the problem without using a flap. One last piece of advice to you about something I learned over time. It's personal experience, not evidence-based science. The implant will always be a little higher than the limit of the dissection zone in the inframemory fold, and the other breast tends to go down over time, even when we do a mammoplasty technique that overcorrect pitosis. If the breasts are very similar in the early post-op, it's a sign of poor symmetry after some months. This is particularly true in the case of radiotherapy, because with capsular contracture, the implants rise even more. So what do you think it's better? The patient who comes out of the operating room with similar breasts and looks bad after a few months, or having asymmetric breasts at first, but a good symmetry for many years? And so that's something to think about. The considerations I made today are based mainly, most of them based on personal observations. You have seen that there is no strong enough scientific evidence in the literature. I invite you to read this article to which we collaborated, published a few days ago on the Breast Journal, with the conclusions of the International Consensus Meeting in Switzerland from the Oncoplastic Breast Consortium about breast reconstruction after radiotherapy. I think we'll find it interesting and useful. I would like to review my preference and let a take-home message for you. Whenever possible, a conservative treatment will be almost always the best and safest option, especially in the case of radiotherapy. It will be lead to less complications and better results. When I have to remove large amounts of skin, I prefer to use an expander, but in most cases, it's possible to perform a direct-to-implant reconstruction. To do so, you just need to detach all the lower origins of the pectoralis major muscles. I let it attach to the subcutaneous tissue and to a small mesh of subglandular fat near the inframemory fold, and I left behind when I do the mastectomy. It will allow you place implants up to size 600 cc if necessary, subpectoral. In some cases, when pinch test is over 1.5 centimeter, I do prepectoral reconstruction without ADMs. I don't believe ADMs help in this case. When there is capsular contracture, when I need to exchange the reanimated expander or implant, I perform fat grafting before removing the implant and before doing the capsulotomy. If you try to do it after, there will be less space for the fat, and if you do it before, you don't lose the grafted fat when performing the capsulotomy. In the case of delayed reconstruction after radiotherapy, I prefer a tram flap or latissimus dorsi or a DF if it's your reality in your country, in most favorable cases. Another option would be fat grafting, followed by an expander in very well selected and motivated patients. The patient must know that she will have to undergo many procedures in this case. Usually patients don't want to do so. When I have performed the mastectomy for local recurrence, I also prefer myocutaneous flap, but I've done some direct implant reconstructions with ADM in selected cases with good results so far. I don't have time to show how I perform such surgeries, the implant reconstructions, capsulotomy, immediate fat grafting, myocutaneous flap, but it's possible to find this and hundreds of other educational video clips on my personal website, oncoplastic.com. I created the website at the beginning of the pandemic to help colleagues and alumni interested in oncoplastic. And after some 2 years, thousands of surgeons around the world are using the website. I'm very happy to be able to contribute in some way to so many people. And again, many thanks to our friend Yassam Assanet and iBreastBook for the opportunity to be here with you. I hope that you stay connected with us from Oncoplastic Academy in new projects in the future.
Great talk, Redis. Great talk, and many thanks to the speakers. And let's remember, we have the Brazilian Breast Cancer Symposium, which is free for people to register. It's in May. So if Regis or Cicero or Maurizio, if you want to share that on the chat function, what's the website, so people can register for that. It's a great 3-day event. And I must thank everybody that has been attending those webinars. If you remember, a few months ago, we've done a survey called the Minim Survey, looking at multifocal multicentric breast cancer. We had 700 of you that has responded to that, and that's now in print as a paper in the British Journal of Surgery. Now we'll start a discussion, because those are 3 controversial issues. We chose 3 subjects, so about an hour of talk and about half an hour to an hour of discussion. And in the panel we have Professor Linda Wild, and Linda is the Professor of Surgical Oncology in the University of Sheffield and a consultant in Doncaster. Also, she's the Secretary of the European Board of Breast Surgery. She's one of the past chairs of the Education Training Committee in ESSO, a member of Board of USOMA, a member of trustees of ABS, and we can continue on and on and on with all the things that Linda has done during her career. It's great to have her with us. We have also Anne Tansley, and Anne is one of the consultants in Liverpool. Also, she's a current chair of the Education and Training Committee of the Association of Breast Surgery and one of the member of the Board of Trustees. And also she's in the training interface group for all the fellowships in the UK. Among many things, both ladies have a huge educational profile, and that will be great for the discussion of the training pathway with Cicero, among the other things. We have Ash Kotari. Ash always joins us, and he's the cancer lead in Gaz and St. Thomas's in London, and also he's one of the breast surgeons there. And it's great to have Ash again with us. And we have Andreas Karakatsanis from Uppsala in Sweden, and Andreas is the one of the surgeons there, and he's also the co-editor for the European Journal of Surgical Oncology. And of course, we have Ricardo Pardo, and Ricardo will be translating to Spanish, but also will be, if you have any questions, he'll be also joining us to ask questions, as he was one of the he's one of the surgeons in Bolton in England now, but also the previous president of the Spanish Society. It's great to have more than 500 people of you online. There's quite a few questions on the question and answer section, and I think the first thing to start is to start with the education and training pathway. So I don't know, Anne and Linda, do you have any comments about the talk by Cicero about the education and training pathway?
Yes, hi everyone. It's lovely to be invited. I was very impressed. I wasn't aware that Brazil had such a well-developed training program in oncoplastic surgery, and that it was recognized as a specialty in its own right, which is excellent. I think things in the UK are a little bit different in that we've been doing specialist oncoplastic training through something called TIG fellowships for 20 years now, roughly 10 or so a year. And over that 20-year period, those trainees have gone out into breast units or up and down the UK, and all breast units in the UK now offer oncoplastic training. And we have just submitted to the GMC an application for recognition of breast surgery as a discipline in its own right. So hopefully in the next few years, we will actually achieve what we've wanted for a long time, which is recognition of breast surgery as a specialty. So we can have our own standards, our own training pathway, our own curriculum, our own exam, and we will therefore have full control over who gets to practice breast surgery. And I think it's an aspiration that every country should have, because I think Brazil and the UK are doing well in this respect, and a lot of other countries have not really started to progress. I also agree with the comments that were made about the turf wars, and this is something that we've had experience of in the UK, and in fact still do. And it's something that we very much tried to work with our plastic surgery colleagues and friends to bring them with us, and have them part of oncoplastic surgery. But I think it always causes a little bit of friction for some. I don't know, Anne, if you wanted to just add to that a little bit. So.
Thanks, Linda. Yes, it's been 20 years in the UK since we've been trying to get recognition of breast as a specialty. And it's only up until the last 2 years where the General Medical Council have finally understood the amount of work, the complexity of work that we offer, and the need to offer equity of access to those skills across the UK. We recognise that even now, after 20 years of specialising in oncoplastic surgery, there is still differences of levels of competency amongst the surgeons across the UK. And of course, that's not a good thing for our patients to have better or worse care depending on where you live and the postcode lottery. So this is something that we're very much sort of trying to sort of fight for. I also applaud your Cicero's idea of when we're teaching oncoplastic surgery, it has to be taught at the very start of training. And whereas in the UK, we have had to specialise in breast oncoplastic surgery in the last 2 years of training out of generally around about 6 years of higher surgical training. I believe absolutely that the principles of oncoplastic breast surgery must be taught at the very start of any training surgeon, any trainee. So that's a really important point to make for anyone who's thinking about putting their own training programs together. I thought it might be helpful just to sort of explain why we've had some challenges in trying to get our breast specialty recognised, and I think that this might be similar across the globe, in that for the current to be a breast specialist in the UK, you have to still train in general surgery. And 20 years ago, when we first started trying to get support for breast specialty curriculum, our general surgical colleagues didn't appreciate how complex our work was. And actually now I think there is an understanding that we are not just ablative surgeons, and the breadth of our skills and our competency is quite huge. So that's one important point that's been addressed over the last 20 years, is the recognition from our colleagues that what we do is really quite specialised. The second area has been around managing the general surgery on call for the population, and this is mainly provided by our registrars and obviously consultant cover. And what was explained to us is that if we took our breast trainees out of the general surgery on call rota, that would put a 20% gap in available doctors to provide emergency general surgery. So that's been quite a huge barrier. And we're sort of mitigating for that at the moment, in that in our last curriculum that commenced last summer in 2021, that our breast trainees can come off the general surgical on call for the last 2 years. So that's a very big but very small step towards breast specialty curriculum, which was a huge achievement. And we are hoping that within the next 5 years, we will have a breast specialty curriculum. And then the third point I just wanted to make about challenges that we have in trying to get a breast specialty curriculum is really is about turf wars. And it's how we maintain our collaboration with our plastic surgical colleagues. And I think that one of the things that the training interface training has done is brought the two teams together and shown that if we work together and collaboratively, that our patients get a much better surface. And one of the challenges and fears that I think our plastic surgical colleagues have is that if we become a breast specialty, they will be left as really just delivering technical microvascular surgery. And we're very, very aware that this is a sensitive area. But of course, we don't want that. We want to be a fully collaborative partnership in breast surgeons and plastic surgeons. And that comes with making sure that we have a very open curriculum, that curriculum is open, and we encourage our plastic surgical trainees to partake in that. And so I think the idea of having that hierarchy, modular approach to training could be very relevant across the globe. And I think what Cicero has presented is a really interesting pathway. This is something that we aspire to, and we'd certainly very much hope that our breast specialty curriculum is accepted, and that we could then share that with the rest of the globe. So thank you for that excellent talk.
So that's exactly like you, Anne. When I saw Cicero and met Cicero and Regis and Maurizio online nearly more than a year ago and see what they do there, and you realize that they have this completely separate specialty training, and does make a difference. It was great that Cicero was speaking about that, and maybe it's something that they had for years, something that we can learn on what worked well for them and what might not have worked as well as they have thought it was worked when we try to incorporate that in ours. And Giuseppe, any comments on that? Because you do lots of training also and education. You are on mute, Giuseppe. We cannot hear you.
Yes, thank you very much. Can you hear me now?
Yes.
Yes. So I really loved your talk, Cicero. You know that we really enjoy your point of view. And first of all, I would say that Greta has been committed to development of training of careers in oncoplastic surgery. And I want to highlight two focus. The first one is about multidisciplinary skills. In the past, we organized a lot of master classes and meetings to let the surgeon not be only a surgeon, but to develop a really multidisciplinary skill in a way that he should be able, for instance, to use primary systemic treatment, every kind of primary systemic treatment, as a sort of a scalpel in his hands to rearrange the surgical technique he wants to use. Obviously, when appropriate, not anytime. This is clear. And the second point I want to highlight from your talk is that there is a change in the way we see the patient, which is not only the cancer, is not only the disease. We have a patient which is not only kind of a, something in a way, an ethic consideration. It's just to have a patient in front of you, which is a human being that is made up of cells, muscles, fat, and also personal values and let's say preferences and desire. And then you need to adapt the technique to what the patient desire. What is the real patient wish and preference? What is the real patient? What are the real values of the patient? So you need to have in your hands a very huge range of surgical techniques that you need to adapt to the patient and not to theoretical skills. And finally, we did a lot in this way, in trying to let the trainees understand multidisciplinary view, that means that they should be able to read also mammograms, be able to understand MRIs and so on. And now my query here is, my question is, to what extent we should develop surgical skills? And for instance, and I go to the clash between plastic surgeons and surgical oncologists. What do you think about high-level skills in microvascular surgery? Can you envisage in the future a breast surgeon who should be able to complete also microvascular procedures at high levels, such as DF flaps, such as other kinds of free flaps using microvascular surgery? Will this be part of the future training of the future breast surgeon?
I think that's a very difficult question to answer. And even if you have the microvascular skills, you might not have the workload. So you need to give something. Either you give the oncology, or you lose a bit on the microvascular skills. And I don't know, my feeling is always that we'll do the oncology and do most of the other things, but the microvascular is for the microvascular, is still for plastics. Some others might disagree with that.
What is your point of view?
Yeah, that's a great question. By the way, excellent points here. Your question about the training in microsurgery, is it necessary to most of breast surgeons? The answer is no. We need surgeons to do oncoplastics, level 1, level 2, breast reconstruction with implants, and to solve their own complications with some flaps, for example, LD flap and tram flaps. And we should have, in terms of maybe the health care organization, centers where it is possible to do this kind of surgery, because microsurgery is important not only for do diap flaps. We can do it, of course, but nowadays we are doing more microsurgery for lymphedema, to correct lymphedema problems, and we have lots of these patients until now, unfortunately. So, in my point of view, microsurgery can be an option for breast surgeons, but not the main active point to training for us as breast surgeons. I think that we should focus, our focus should be in the day problems that we have every day in our theaters, in our public health care situations. I love at some points from our colleagues from the UK too, because we always look at your model of training in the past when we began to do oncoplastics, and we tried to do and to put the oncoplastics inside our country. And one thing is that I think that every country should aspire to do breast surgery as a specialty. It's much better, believe me. If you want to come to Brazil, or if you want to share the experience that we have since 30, 40 years ago, when we began to do breast surgery as a specialty, certified as specialty here, you see that it's much better to work in this way. It's much easier. The second point, very, very short, not about the plastic surgeons afraid to be just microsurgical surgeons. Most of plastic surgeons wanted to go to aesthetics. Some of them wanted to be with us and all full-time dedicated to reconstruction. They have space. I love to work with them. It's not a problem. It's a way to do much better collaboration and surgeries together. We improve our treatment to the patients, and we can learn each other. The word is collaboration, not war, not turf wars. This is the best and should be the best.
That's great. And before we move, because we have about 20 minutes discussion for each point. So before we go to the implants, Linda, you had your hand up. Did you want to mention something before you go to the implants and breast conservation?
Yeah, just a very brief point about the turf war issue, which at the moment, women don't have equitable access to the full range of organs because there aren't enough plastic surgeons in the UK. I don't know if that's the case in other countries. And so rather than being threatened by the development of oncoplasty, they should see it as an opportunity to increase the number of posts that there are so that they can provide this service to every woman who's potentially eligible. Because at the moment, because of COVID, we've got huge waiting lists for free flap surgery in the UK, and some women simply aren't referred because they would have to travel such a long way and wait for such a long time for it. So it should be seen as a positive thing that the plastic surgeons can engage with to help to develop their workforce capacity. You know, I think they need to view this as an opportunity rather than a threat. And
yes, I don't know if I could comment on this question of training. Cicero said that the word is collaboration. I would like to add something. I think the key word is training. It's not because you are a plastic surgeon you are able to do the breast reconstruction. I received some plastic surgeons under my mentorship because they told me that they've never seen in their residency and their specialization a single breast reconstruction. They've never seen a breast reconstruction in their lives. And they came to us to see how it works. And it's not because you're a plastic surgeon or if you are a breast surgeon or a mastologist like in Brazil that you are able to do breast reconstruction. I think it's very important to incentivize people that want to learn. I don't think that everybody will learn oncoplastic surgery, not here, not anywhere, because not anybody would like to do all the tough work and training. It's a lot of techniques, much more risk of complications. So some people would be interested in oncoplastic surgery as breast surgeons or plastic surgeons. I myself, as breast surgeon, I do breast reconstruction for many other colleagues here in my city. Many people call me when they have to do a breast reconstruction, and we work together and we collaborate. I don't think it's matter if you're a plastic surgeon or a breast surgeon. You just need to have a very good training. That's the most important point.
That's good.
And as a society also, we are also worried about the ones that have finished the residency, the specialization, and now they want to learn something about oncoplastic surgery. And we organize some courses. Me and Mauricio, we organize official courses from the Brazilian Society of Mastology. And people come to our city every month during 11 months, and we perform together over 100 breast reconstructions in 1 year. It's another model. We also organize courses in pigs and cadaver lab with Cicero in Curitiba. And I think it's important to have the opportunity for those that want to learn, that have a good, very good practice and very good training.
Thank you, Magis. Now let's go to the implants and breast conservation. If you're interested in attending the Brazilian Breast Cancer Symposium, Eleni Demetrio has put it on the chat function. Just can go and log in there and you can join for free. It's in May, mid-May. Now, breast conservation and previous implants. We know there's about 40,000 augments in the UK a year and 120,000 augments in the USA a year. So it's a common problem that we're seeing more and more now. Andreas, we don't want to bore you, and also Ash, we don't want to bore you. Any views on breast augmentation, breast conservation, augmented breasts?
Well, that's a very, very interesting discussion. We will go on for much longer than 20 minutes.
Yeah.
Yeah. Well, for starters, we need to make it clear that our clinical reflex is not evidence-based. Okay, what do? Do you perform mastectomy and go for a larger implant? Do you perform breast conservation and remove the implant? Do you keep the implant and do the breast conservation on that? All these options seem to be viable as long as patient selection is performed in a sensible manner. Are we going to get any evidence anytime soon? I think not. I think not. The current literature does not allow the conduct of meta-analysis that would provide with substantial evidence that would address this matter in a definite manner. I think that this is a decision that should be tailored according to patient tumor factors and patient preference, as well as surgical availability. And the important thing in order to keep quality standards is to prioritize the oncological principle, as we always do, and prepare the patient for each worst case scenario, because this is the way to do things, especially when the evidence is not very, very solid. Recently, we had an internal discussion, Ash knows about it, through emails about how different people do. I think that this is something that we could address in a more scientific manner by means of a survey or something like that, but still building on evidence would be a challenge. I don't have a personal preference. I don't have a standard practice. I adapt to where the tumor sits, what needs to be done, and what the patient prefers, and what the patient is prepared to tolerate in terms of complications. You're muted, Yazan.
Ash, any views on that? Yeah, I'm still, even after 2 years, I'm still talking when I'm muted.
I just would like to echo exactly what Andreas has said. You can't have a one brush paints all picture in this, especially for people who have seen patients who've seen complications. It has to be tailored to the cloth, basically. You have to cut the cloth that you have. Radiotherapy has, I think, because we have people, trainees online as well, we need to understand that radiotherapy is not just an immediate effect that you see. Radiotherapy has short-term effects so that you can see within 9 months, and then it has a biphasic effect that lasts for years and years and years. It has a profibrotic effect. It has an effect on the vasculature, so the microvascular environment in the breast changes completely, and that is why you end up with more complications. So if you operate in a radiated breast, that's why you end up with more complications, more fat necrosis and everything else. So you can't actually generalize, but yes, if you can. And the other thing that is very important to understand is if in a woman who's had an augment for very long, if you look at the mammograms, you have a very thin rim of breast tissue, and you could see that from the video that Maurizio showed. That there is hardly any breast tissue there. So then when you're trying to do conservation in these patients, obviously you're going to face a volume loss and you have an indent, and then you have to fat graft. So if you can avoid radiation, great. If the patient doesn't want to have radiation and an mastectomy will address that, then yes, that's again comes into consideration. The other question that all the speakers spoke about, and probably I might as well get it out now, is from the training perspective. I mean, we are very fortunate at GUYS. We have breast surgeons, we have 8 plastic surgeons. There's enough work for all. We do more than 220 reconstructions a year if you look at implants and autologous. I think I agree with what Cicero had to say, that there is room for everyone. The breast surgeon should be able to do their repertoire really well. And then there is always room for the oncoplastic microvascular surgeon. We are now in a stage where, at least I'm seeing that more and more, you're doing more stacked flaps. I don't know how many people are doing stacked flaps. People are doing, so in recently one patient didn't want to have implants. She had 4 flaps. So she had a DIEP and a PAP on each side. Now, is that something that you would advocate? No, but that's what she wanted. She wanted 4 scars. She wanted 2 scars on her thigh, 1 on her tummy, and 2 on each breast. You can't change that. So there is a preference there. It is becoming more and more complex. I think one of the things that we haven't mentioned in the education part is having a very good functional oncoplastic MDT, which we are fortunate to have, where patients with complications come back, and then you can assess them jointly with a fresh perspective of a microvascular surgeon and come up with something which will benefit the patient. In terms of the evidence that was shown of radiation and capsular contracture if you do an implant, I think I know Peter Cordero really well. All his implant reconstructions are submuscular. You don't have the ADMs in Brazil. So again, you partially put your implant subpectoral. I know that Cicero and Regis have recently been doing, and Cicero has a large series of prepectoral without any mesh. And his results are great. But there is evidence to show that if you use an ADM, then there is less capsular contracture. Why it happens exactly, no one knows, but it is to do with fibroblasts and myofibroblasts. So there's a very good paper published by Kim et al. That looked at patients who had expander reconstructions, partially submuscular and partially with prepectoral. And when they went back to exchange, they did a biopsy of the subpectoral part of the capsule and the this was ADM, so the dual plane expanders, and they looked at the biopsy under the ADM, and the ADM had a capsular contracture or capsule formation, which was 13 times less than the submuscular part. So the ADMs do help. We are fortunate that we don't have a problem. But when you look at the health economics, which you say, ADMs are expensive. Yes, ADMs are expensive, but if they prevent capsular contracture, they prevent patients coming back, they prevent a second operation, they prevent a capsulotomy, then of course, in the long term, it all evens out. So in short, I think Andres is absolutely right. There is no evidence, there is experience. And then what it shouldn't be is eminence-based. So in the lack of evidence-based, there should be experience-based medicine and specialization. But it shouldn't be eminence-based because I say in my hands, this works, so that should go. It's not an easy, that's why it's a controversy. There isn't one answer for it.
So there's some questions many people ask about the capsule. I think Ernest Newton, who works in Taiwan Hospital, which is the main cancer center in the Emirates. Peter Barry was also asking, which is in the Marsden. Some other, also Prof. Nishan from Beirut was asking the same thing. Why to do a capsule? Why do you do a full capsulectomy? The capsule is not part of the issue. Do you always remove the capsule, Mauricio? You're on mute, Mauricio, I cannot hear you.
I saw this question, but I think there's a mistake in it. The capsulectomy is not treatment of cancer. The capsulectomy is capsulectomy, that's it. We are treating cancer, then the lumpectomy is the treatment of the cancer. If we remove the capsule, in this case, that the implant was retroglandular over the muscle, then we can take it out. Then it's better for a long time, because if we have a capsule and it yet has a small contracture, we can delay a complication with capsular contracture. Then the capsulectomy was made to prevent contracture in the future or to delay contracture in the future, not for the treatment of the cancer.
Anybody else?
I think
Ash?
I think the other thing you could do is, if you don't have a capsule contracture, you have a nice flimsy capsule, you could always preserve it. You could take the capsule, just a window under the tumor, preserve it, and then put an implant back in the same capsule. You prevent using an ADM in these circumstances.
Yeah, I do. I completely agree with you. I completely agree. Yeah.
I sometimes when it's a small tumor and you don't need to put a bigger implant, you can just remove the cancer and shave it off the capsule, and your posterior wall is the capsule. You don't always need to touch the capsule. Do you always remove the capsule or part of it? I wouldn't touch it. It's a small tumor far away from it, and I'm wearing the implant.
No, I would agree. If it's not touching it, and don't necessarily take it away. But if it's a thick capsule, then as has been said, it's beneficial to take it out anyway. So.
Any comments about, because lots of people are asking about radiotherapy and conservation. What's the rate of capsular contracture that you've seen with that? Any comments on that?
Again, I think that there is no evidence, and if we start discussing, let's put another parameter in the game, because this is even more important. Up until now, we have been discussing about our experience or what observational studies show in the context of whole breast radiotherapy. Let's just not ignore the fact that when we are talking about whole breast radiotherapy, the 1 week protocol, which is trending to be the new reality, is not the same thing with the 5 weeks that most of the older studies refer to. Let's not forget the fact that there is no specific data on patients with a background of implants in the context of partial breast irradiation. Let's not forget that these new techniques from the radiation oncologists will be the new standard, and it is not a matter of years, it is here and now. It is just that in a couple of years we will be seeing these patients, and we will be having completely different considerations, since we may be able to re-irradiate, or we may have other type of constrictions, such as that an area that has been previously only partially irradiated and boosted will not be amenable to any other local treatment with the safety that we have been used to.
And let's not forget the evil in the room also, the boost or no boost. The boost also, I think, makes a big difference. And many of those ladies are young ladies, so many of the radiation oncologists will give them boost. Shall we, since we're talking about radiation, shall we go to the radiation part of the talk, which is radius? Giuseppe, have anything to comment on that?
Well, yes, thank you very much, Yazan. Thank you very much once again. It's a topic that that we dealt about for a very long time in the past, and we published one of the longest series about irradiation on tissue expanders versus implants. To be honest, once again, nowadays I believe that breast radiotherapy, post-mastectomy radiotherapy on implants is something that I want to avoid, and I prefer to use an implant in the first instance when I'm doing the mastectomy, and then refer the patient to the plastic surgeons to do a DF flap after radiation. I just want to leave the patient with something to fill the bra. I mean, with some kind of breast reconstruction, but then convert this to an autologous tissue-based breast reconstruction. And the other thing that I want to highlight is the use of fat grafting, which is certainly a powerful tool in our hands, but again, no evidence, no reliable proof of its functionality. We don't know the dose, we don't know the timing of injecting fat. We know that sometimes it works, and it works very well. But again, very poor information about this. And the other thing is that when we use the other thing is that the architecture, the design of implants is still very, very poor, because we are still using the implants that were designed and developed more than 30 years ago. And this is not possible. We need to develop studies starting from preclinical studies to understand another way of performing implant-based reconstruction with new devices, maybe a new architecture. So 3 points. My preference to DF flap and autologous flaps in the setting of post-mastectomy radiotherapy after an implant, a temporary implant-based reconstruction. And the second one is the use of fat grafting for treatment of post-mastectomy radiation. And the third one, what do you think about development, new design of implant and implant-based reconstruction? Thank you, Regis.
Thank you, Giuseppe, for the considerations. I completely agree. Many years ago, when I had a patient that had to go through that I knew that she would have radiotherapy, I would prefer to do a trunk flap or a latissimus dorsi to have less effect of the radiotherapy. But some of these patients still have some effect, some fibrosis, some contraction of the flap. And so I changed my mind, and now I prefer to perform a temporary reconstruction with expander or implant. And after it, I can analyze if the patient is satisfied with the reconstruction. Okay, we don't need to change anything. And we know that not all patients will have complications. The rate of complications are higher, but not all patients will have complications. And if the patient is dissatisfied, we can manage the better case. We can manage with fat grafting, capsulotomy, change and expand the implant. But for worse results, we can always perform a flap. And so I think nowadays it's my preference. And I think ADMs are less. I believe that ADMs can avoid capsular contracture because I saw it by my patients. They are not so many, but I used it sometimes, and it works. But I think fat grafting will be the best option in our reality if we want to avoid a flap. Because it's much cheaper, much easier, and we have more studies showing some effect against radiotherapy than with ADMs. ADMs is controversial. We have randomized trial that show more risk of infection, seroma formation, etc. And so I prefer to use fat graft instead of ADM when I want to preserve the implant-based reconstruction. And in respect of the new materials, I completely agree. And I saw some studies, but I never see the results. Some kind of ADM that works as an implant. It is repopularized with cells. And there are a lot of futuristic things that I would. I'm rooting that it works and it comes to practice, but it's still with what we have. Implant the old implants is what we have.
That's great. So we have Andreas, then Anne, then Ash with their hands up. So Andreas, do you want to start out first?
Thank you very much, Yazan. Regarding the setting of reconstruction or reoperation in the in the irradiated breast, we know that this is not a good scenario. This is something that we would like to avoid, of course. I would just like to, apart from saying that Regis did an excellent talk on the matter, I would like to advertise one of the papers published at the EJSO, which I think is a very good paper by O'Donnell and their team. It is a network meta-analysis of the optimal reconstructive strategies in the setting of performing a mastectomy when you are awaiting irradiation. They show that autologous reconstruction is the way to go, and if not, then you should consider, if you consider implant, then you should just put it before irradiating. On the basis of these results of this meta-analysis, we can understand that our primal fear of delaying things has to do with mostly fear. I know that the Prada study has recently been accepted for publication, and we see that now we see that if you go just right after neoadjuvant radiation therapy, delicate operations such as DAP reconstructions are possible with a very, very good safety and tolerance profile. So what do we do for the breast that has been irradiated? It seems that fat grafting can fertilize a sterilized area of tissue. The evidence about it is still limited, and I think that we need translational research. We need to go back to the basics of science and understand the mechanisms that make fat grafting efficient sometimes and not efficient at all at some other times. When we need to go to the irradiated breast, however, it becomes clear that we need to make a very clear radiological and clinical assessment of the quality of skin, of the quality of the parenchyma, of the damage that the radiation therapy has already performed, and tailor the treatment that we need to offer according to these parameters.
That's great. And Anne, did you want to say something?
Oh, I completely agree that with Professor Contracture. I prefer to.
I'm not a professor. I'm not a professor.
Oh,
I'm mere mortal. I'm mere mortal. Okay.
I completely agree. I prefer to. I usually advise patients that have bad results with the implants. I advise them to perform an autologous reconstruction. I think it's better. But there's also some patients that don't want to undergo a complex surgery like this, and there are some alternatives, and that's what I wanted to show you, some of our case and our experience in these alternative options.
That's great, Regis. And
thank you. I was just going to comment that we're using so much more lipomodeling in our practice in the UK. Certainly following radiotherapy and implant-based reconstruction, it can have significant improvement on the quality of the skin and improvement of the capsular contracture pain. I just wanted to ask a question really, whether any of the panelists, and I think Mauricio did mention this in his talk, are using primary lipomodeling. This is something I'm doing at the time of reconstruction, at the time of breast conservation is doing lipomodeling at the same time, and whether that's a trend that's becoming more widely used across the globe. It's a question, I guess, to everyone.
I think Eduardo Gonzalez gave a very nice talk from Argentina on one of the previous webinars on that, and they use it routinely in Argentina. Do you use it in Brazil, primary lipomodeling, when you do the excision?
Yes, I use it very often. I know that there are some regards about the oncologic safety, but we have a colleague in Brazil called Biasus from the south of Brazil that he published the results of the immediate fat grafting, and he has a large series and a large follow-up, and I think it's safe. I've done it more than almost 10 years that I do immediate fat grafting in some patients. It's a good way of volume replacement, and it helps to do partial breast reconstruction. I think it's very useful.
Ash, do you have any comments?
So there's one point on doing immediate fat grafting post breast conservation. So if you look at the science behind lipomodeling, it works because of neovascularization. It, like Andreas said, it creates a new environment. It's a fertilizer. So if you're doing lipomodeling to do a cavity refill, you're then radiating that. So the advantages that you have, and you can get your lessons from free flaps. So if you put a free flap, which is fully vascularized and radiated, you have a 15% volume loss, you have a pro-fibrotic effect, you have a texture change, and it feels rubbery. So if you're trying to do something at the same time as to fill the defect with fat, or to contour with fat, then in my opinion, again, there is no evidence, and this is just an opinion, that advantage that you're purporting to gain may be lost. That's just one point. The second point is what Andreas said. I was going to say exactly the same thing, is there is evidence that in patients who are going to have radiation therapy, an autologous flap does better than an implant reconstruction. But if you want to use an implant, then a delayed immediate is always better, where you put an expander and then you swap with an autologous later on. And the good news for Giuseppe is, I can't name the company, but I am advising the company on exactly what you said, because I can't work out, for the love of God, why do we have to have a hybrid of having an implant and an ADM? Why can't they just come up with an implant that's sprayed with ADM? Yeah. And trust me, it's happening. The problem is trying to get that to stick. So there are companies that are working, and in fact, there is a company in Switzerland which recently showed me a product which is great, which is basically a spray. It's like a foam. And you spray it into the cavity, it sets, and it gives you the same benefits that the ADM will give you. So it allows for neovascularization and tissue growth and tissue ingress and everything else. But of course, we're far away from actually it becoming in routine practice. But these things are coming. If they are listening to us, so hopefully something should happen.
Thank you very much for this comment, Ash. I'm very reassured. But my idea is that we need to think about the whole concept of implant-based reconstruction. And for instance, leave the muscle and that we try to leave the concept of the muscle as a filler, because many times we are seeing so many speakers talking about the muscle as a filler, but the muscle is done to make a contraction, to contract. That's why it doesn't work. And it is something that we need to see as the whole concept of implant-based breast reconstruction. So thank you very much for your updates.
So it's nearly 6 o'clock now. We have less than 10 minutes left. I just want to ask a question for all of you. If somebody had previous wide local excision and axillary surgery and had radiotherapy and have a new in-breast recurrence, how many of you will consider doing wide local excision again?
Can I please take that?
Oh, please do.
No, I'm just okay. Now I'm just whistleblowing and cheating a little bit. But we recently completed a meta-analysis using a different methodology than a previous meta-analysis, just to make sure that we're not skipping anything. The evidence is low, but it seems that it is not. It is not an alternative that will be that will burn you in hell after Holy Inquisition anymore. I think that this is something that starts to become acceptable. What I think we should be doing is looking at the patient from a clinical and oncological point of view. It is the biology of the primary tumor, the biology of the in-breast recurrence, the expected treatment for the patient, and the toxicity of the treatments, as well as quality of skin, parenchyma, the cloth you have to work with, as Ash said, and more or less something that we saw in the literature review. We need to make sure that the studies we do from now on are better, because the available evidence has not been better throughout the years. That's my 5 cents in that.
Because my thoughts is always, if they have some ladies in their mid or late 70s that have a small grade 1 or grade 2 or small area of DCIS, that in normal practice, sometimes you don't give them radiotherapy anyway. So if that breast recurrence was in somebody in their late 70s, small grade 1 or grade 2, favorable biology, why not just do a lumpectomy and do nothing more? Why should you use the breast? Isn't that an option?
That's sensible. That's sensible, but it goes opposite to what we have been used to doing until now. That's the thing.
It has the eyebrows in the MDT when I mentioned it once, so I stopped mentioning it.
I feel that we need to look into the future, because, as I said before, we see now that partial breast radiation is becoming clinical practice. It has become part of the guidelines. It becomes a quality indicator from now on, and so on. So I think that this is something that will open new opportunities and will create new clinical settings in the future. And what we need to do is to have quick reflexes and to design studies that will address the possibility to have high quality data on that.
Any comments on that, Linda?
Yeah, I offer redo conservation, subject to tumor biology, patient characteristics, previous cancer. As you say, the ideal thing is a small recurrence in an older patient. You know, I think it's a reasonable option. I agree with Andreas that we need to do some research more widely. There is stuff published out there looking at this small series, and in fact some larger series now, that show that it's actually safe in selected cases. But I think we probably need some more research just to refine the criteria.
So before we go to the last few comments, there's still 450 people online. Remember, the next webinar is on mastectomy. We have about sensation preserving mastectomy, sensation restoring mastectomy. We have a Goldilocks, and we have also Nicola is going to speak about implants and skin sparing mastectomy. So that's in 3 weeks' time. We have great speakers and panelists, and we have a few other webinars that are penciled in for the coming few months. So keep an eye on the newsletter that you'll get. It's nearly 6 o'clock, but I know Cicero wants to say something and Andreas wants to say something. So Cicero, what do you want to say?
Regarding to this question about the recurrence and to do a breast conserving treatment in the recurrence, it all depends. It depends not only on an oncologic way, but in the aesthetic result after your surgery. If it is possible to have a good result doing, for example, a local flap or maybe lipofilling, maybe you can do something in this way. But if you have a disaster in a breast conserving treatment, maybe it's better to do a mastectomy and to do a reconstruction with a flap. So that's my view. I think always in both, in aesthetics, in an oncologic way.
And Andreas, you didn't say something?
Yeah, just one thing, just an input from Peter Barry, who's in the audience, and I have posted the link to the chat. The UK has launched a prospective audit, the Mareka study, looking into the management of the local regional recurrence for breast cancer. I think that this is a brilliant initiative. I think that this is the way that we need to move forward with in order to see how things look like for these patients. We need large data, we need real world data, we need data that will look into the oncological outcomes, but also on quality of life, complications, health economy, all these things. We need to make sure that we get them from now on. And I think that this is a very good example of how surgical research should be from now on. We should try to, answer to the questions in a systematic manner and very, very clear for everybody.
Ash, is your hand up or is that from previous?
No. So just to add on to what Andreas said, I know you came fashionably late to the SO Congress last year, but Linda was there and Andreas was there, and Philip Portman's gave a lovely talk on re-radiating the breast. And also remember that radiotherapy is not the only answer. There's also hypothermia that you can use.
Yeah.
So there's lots of things, and it has to be tailored medicine. We're moving there, but eventually we'll get there.
Yeah, that was an interesting session because it was Philip Purmas that talked about re-radiation, and it was Mario Stasoulis that spoke about redo lumpectomy. This was the first results from this project that we are now doing. And I think that there is a very, very, very promising field for further development and research in this setting.
Comment from Regis and then the final comment by Giuseppe. Is that okay?
Yes. Before the farewells, I just want to talk again, Yasan, for the opportunity to have the Oncoplastic Academy with you and with the other professors, except for Karaksanis, who is not a professor.
Not a professor also.
Sorry, no, it was really a pleasure to be here. And I'd like to invite you to the BBCS, the Brazilian Breast Cancer Symposium. I just put the web link to the chat. It's free of charge. It's the largest congress in Brazil dedicated to breast cancer research. There is also time until tomorrow to register your research paper there. There is prize up to $2,000 to the first prize for the best works, and we'll have many of you as a speaker there. It will be an honor, a pleasure to have you there, and I hope you join us. Thank you very much.
That's great. Giuseppe, final words?
Yes, finally, very quick. Thank you very much to all the participants to the meeting. Once again, you will find the paper that has been published on the BJS in your mailbox, and it's free. Thank you very much once again. Thank you, Yazan, for inviting me to this session.
So, thank you, everybody, for giving up your Saturday. Linda, you have your hand up. You wanted to say something?
I was just waving to say goodbye.
Oh, that's fine. Thank you, everybody, for joining us on the Saturday, giving up your time for both speakers.
Thank you all.
And for people in the States and South America, have a lovely day. People in Europe, have a good evening. And the subcontinent and the Middle East, have a good night. Thank you, everybody.
Thank you, Hassan. Thank you.
Bye-bye.
Bye, guys. Thank you.